I work as a partner across Erewash Health Partnership, and that's a merger of 10 GP practices in Erewash. We're working to improve the sustainability of general practice in our area so that we can serve our population and try and improve the service offering. And one of the things that's come out from meetings with the public, meetings with the staff, meetings with the partners, is the problem that we see in our community of isolation, of loneliness, and the ability for people to try and tap into the resources that are there. Bridge clubs, walking groups, knitting clubs, there's a whole variety. And so what we've been doing over the last couple of years is working really hard to try and connect our community up with those individuals that would really benefit from it. And we've been working with the community groups, with the ambulance service, with a variety of other organisations to try and bring those people together. And in the last 6 months, we really focused then on general practice staff, and we're trying to train them up. We've given them a label of community connectors. And they are people that start to develop an expert knowledge of what's going on around them. Last week we had a drop-in session in Long Eaton Health Centre, so one of our health centres, and we had over 16 people turn up. The common theme throughout all of them was around loneliness and isolation. A lot of them have experienced a bereavement in the last couple of years, and they just felt as if they needed a reason to get out of the house and a reason to do something. And when we look at our cohort of high-using patients, so individuals that come into the surgery, you look at some people, and across Erewash we've got over 50 people that are attending their surgery more than 50 times in a year. And there's absolutely no way that we are addressing their medical need in them attending 50 times in a year. It's just, we're not doing anything to improve their health. We're completely missing the point of why they're coming in. And what we don't realise is the burden that has on a broader health system. And what you find is one of the common threads for this group of people is that actually they feel alone, they feel worthless, and they feel as if they've got nothing left to give. But by connecting them to their community, they start to have a sense of being valued, they start to feel as though they have something to give back, they stop feeling worthless, and amazingly they stop having to make contact with their practice. And what's really exciting about that isn't that I have less work to do, is that actually I can then start offering those longer appointments. I can then start addressing the really complex medical need of some of the individuals in our community, and those that were turning up 50 times to see one of my colleagues in one of my practices, they're now not having to do that. And it's amazing. It shouldn't be a sea change. And if you think about where the ideas came from, they didn't come from someone in an ivory tower distant to the community. They came from the receptionist staff who live within a couple of miles of where they work, who interact with individuals on a daily basis, and it comes from the patients. So actually the cultural change was very, very easy. The challenge is, and the challenge has been and still is, making it as easy as possible for people to make those connections. Because as soon as you call something social prescribing and you put in the obstacle of having to see a GP, and that being a conduit into connection to the community, there's a barrier, and you start medicalising a problem. And as soon as you suggest there has to be a funding stream attached to it, it starts complicating a process which, as you said, is entirely simple and should be straightforward.